This
some
conference will now
stations
be
which
recorded.
are likely to appear in face-to-face exam, because we know that most of you have been preparing, and all of our candidates also seem to be a little scared that suddenly, we have been practicing for the past a year or so for online, and we are worried about having a face-to-face one. So these stations will pertain to the times when we had a face-to-face exam. All of us have answered in the face-to-face itself. So hopefully doing these tasks today here will help you to orient yourself better to the way you will be assessed in face-to-face tasks. Okay, so that's the purpose with which we are doing this. I will need 4 names right at the beginning.
Can I, Dr. Ankita?
It's Dr. Uma actually.
Oh, sorry, Dr.
So,
Sorry.
yes, sure. That was Manikam, I think. Was it?
Salma.
Salma, yes. Okay, Salma. Writing your name down. And you've joined from the laptop, hopefully, right? Because we'll be sharing content which will be needed for you to um, use in your task. Okay?
I
Why I'm
just
asking?
I'm with mobile actually. I didn't open the laptop.
You could try to sign in with the laptop. Also, keep a
Okay.
pen
Okay, I'll
and
open.
pencil and a paper with you. A pencil and a paper with you. All of you who are performing today, please keep pencils and papers with you. Okay? Anybody else? Hello? Mm-hmm. I see Kavya here. Kavya? Nusrat, Chandrima, Anikam. Hello?
Yes, ma'am.
There's some familiar names. Chandrima,
Ma'am,
a pen and paper or pencil or paper with you, and log in with the web. Okay?
okay. Yeah, ma'am.
Alright, then let me know when you are set. Okay?
Yes, ma'am.
Ready, guys? Okay. Alright. So I'll be sharing the first one with you, I suppose. Let's begin.
I didn't open the laptop till just on.
Okay. Whoever's ready. Whoever, whichever one will be.
No. Yes, ma'am.
Done? Let me know, guys.
Yes, ma'am. I'm ready, ma'am.
Chandrima. Okay, fine. So, alright. With face-to-face exams, you are likely to get a certain multitude of tasks which you would not get in your online exams, right? So, which includes, one of them includes filling of forms. So there are various types of forms fillings which have been tested in the past in the face-to-face circuit, including for our exams. There were tasks where we had to write down or fill forms. So you have to be aware of what these could be potentially, and you have to look through how these forms are in used in the NHS and familiarize yourself with the pattern, and also have an understanding about what will be tested if these forms are being asked to be filled. So what are the principles of filling certain things? So, filling of forms is a very, very different kind of task compared to your routine consultations in the OPD, or even in teaching of these forms. there are certain principles, okay, which are tested, which are very, very important in passing these kind of stations. All right. So, what are the essential principles needed in filling of consent form? Okay, MDT referrals, prescriptions, which are very specific points to each of these will be marked with star points, and if you do make a mess in only that particular point, you may lose out on the station, which may be very, very important. Okay, so you have to understand in each of these tasks which are those magic or important points which RCOG expects you to never forget or be very cautious about. Okay, so coming to the first one, which is one of the recent ones which came in the latest face-to-face exam which was held. Okay, so we will begin with Dr. Salma. Are you ready? Hello, hello, guys.
Yes, can you hear me?
Quickly, quickly. Yes, ready?
Yes.
Yeah. Okay. Displaying your task. Before that, just very quickly, when I give you a particular form, which I will be displaying on the screen for you, you
Okay,
have to read through
next,
the
please.
form and you have to fill in front of you. There's a paper, right? You have to fill in what you would ideally write in this particular form. Okay, or don't need to copy the form as such. Write what you would fill in the form. All right, clear?
Okay,
Okay,
next,
yeah.
next,
So
please.
let me know when I can. Yeah.
Yeah, next. Any more?
Not as of now.
Okay, the first one, please.
Mhm. Yes.
Hello, I'm Salma Istipab, and you are?
Yes, I am Uma. I am the ST1.
Mm-hmm. How do you, Ma?
I'm good.
How is your
And
training?
yes,
How
it's
is your
going
training
very
going
well.
on?
It's going very well.
Mm-hmm. Good. So, Uma, if you have any problem, don't hesitate to contact with me. I'm here to help and support you. Okay?
Sure, sure,
Yeah.
Salma. Yes.
Yeah. So, Uma, how can I help you today?
Well, I believe that you have just observed the episiotomy that I've done, and I feel like I've done a very good job there. And I was hoping that you could, sign this summative OSAT for me.
Mm-hmm.
Hmm?
Yeah. So is it okay before discussing with the summative OSAT, if I'll ask you some question, then we'll discuss about how you have done this
Definitely.
episiotomy, yeah, and then
Yes.
at the end we'll give feedback each other. I'll give some materials if needed. How does it
Yeah,
sound?
sure. Sure.
Hmm.
Yes.
Yeah. So Uma, you have done this episiotomy. So is it your first time, or before also you have done?
No, no, I have been supervised for episiotomies before, obviously.
So how
Yeah.
much you have done before?
I think about 10 or 15 cases so far.
Yeah. So how much you take sign from the senior?
I've never done OSATs actually. In
This is
my
your
first
first
one,
time.
yeah. Yes.
Okay. Yeah. Um, so have you read this episiotomy from the guideline? Is there anything you want to know about the episiotomy?
No, well, I do feel I've got the hang of it, and I was just hoping that, we could proceed with the signing. And I've done a good job, so I feel that you can sign the summative one for me as well.
Yes, sure. I'll do for you. But before that, I would like to explain you something that about the episiotomy. Yes, I
Mm,
can see that episiotomy, what you have done. Yes, you take consent. You have done the episiotomy that 0.5 centimeter. Before that, you took the stitch. Yeah,
mm,
and
mm,
also you mentioned everything suture materials. You have done this proper third stage management also. Okay, so only the things that um, what I noticed that to uh, that not using the guarding the
mm,
needle.
mm, mm.
Hmm. Yeah,
Okay.
and
Uh-huh.
also the handle the instrument correctly. So what do you
Hmm.
think? Do you think it is important to do that?
Well, yes, definitely. Now that you mentioned it, I will look into that and I will improve next time.
Mm-hmm. Can you tell me that what can happen? Is there any complication can arise if you don't do that?
You can, I believe you can get needle stick injuries, perhaps.
Yeah, if you not guard the needle properly, it can slip
Mm,
off. There could be injury. There could be, bleeding. Yeah,
mm,
so it is patient safety, isn't it? And we have to handle the instrument also correctly. That to
mm.
do the procedure safely for
Right.
the patient safety.
Right.
Yeah.
Yes, I agree.
Okay. Yeah. So, and you had the knot also that you take a good technique. Also, you tie properly. Yes, this I appreciate. Other all you have done properly. Yeah.
Yes, thank
Okay.
you.
So as you have done it, that there is some concern about the patient safety. So actually, I'm sorry to say that I cannot sign for you with this, that which and you have done that not proper way. That means to guarding the needle and
Oh,
also to handle the instrument correctly. So
oh,
I can give you another appointment, yeah, so you can do with me, or whenever you are free, you can let me know that you can come in the delivery suite. I'll show you that how to handle the needle and
hmm.
also the instrument, yeah? Or you can do under my supervision any day when you are free. Okay, then I can sign
Yeah,
for you.
Salma, but I was thinking that my colleagues have also had OSATs being signed for them. So I just was wondering if you could really help me with that. Maybe.
Hmm.
Hmm?
Actually, your colleague and you are not same condition, so she has done everything properly because I didn't see her OSAT, isn't it? Yeah. So
Okay.
it is patient safety. If you do everything competently and you have done nicely, then I can sign for you. And you need total three sign off. Yeah, for me
Yeah.
and any other senior colleague also, and one should be with consultant. Am I clear,
Mhm. I see. Okay.
Uma?
Okay. I
Yeah.
understand. I
Mm-hmm.
understand. Yes.
Mm-hmm.
Hmm.
So we
Okay.
cannot compromise with the patient. Yeah, it is most important that we have
Of course.
to
Of
go
course.
for it.
Yeah.
Yeah.
It's very important. I do agree. But I was hoping at least if you could tell me where I could correct myself.
Yeah, that what I told you, that to handle the needle, yeah,
Yeah.
that guarding the needle, okay,
Mm-hmm.
and
Mm-hmm.
to handle the instrument correctly, okay,
Okay.
like that to when you are picking up the that apex of the episiotomy, when you noticed, okay, you have to
Mm-hmm.
hold it with the needle, that where it is, then you have to take the stitch from 1 centimeter above, okay, and also
Mm-hmm.
the where you will take the uh, uh, tissue forceps, where you will hold with the that artery forceps, everything. I'll show you. You can come and in front of patient, I'll show you everything. How does it sound?
Oh, yeah. Okay. Sounds
Yeah.
good. I think I
Okay.
can do that. Is
Yeah.
there anything else for me
Do
that you would
you
like
have
me to?
any other things I can help you? Do you need that anything else?
No, I was just hoping for the same thing, which is OSATs, if you could sign for me. That's all I wanted.
Y- Yeah, this OSET actually I can sign for you after filling this form that yes, you are doing this episiotomy competently. So I can write here that yes, that that towards the competency. Can you show me this? Yeah.
Yeah, sure.
So I can sign here for you that towards the competency. Okay. But when you have done completely, then I'll check here that trainee perform this observe procedure competently. Okay, then I can
Okay,
do this.
fine,
I feel this
fine.
all of these things, then I can do it. Okay.
Okay, okay.
Do you have any question?
No, not at this point.
Okay. Yeah. So how does it sound? How is the session, Uma?
Well, yes, I did learn that, I have a few flaws and I need to improve on that.
Mm-hmm.
And I'll definitely try to do better. And when I
Mm-hmm.
feel that I'm completely competent, maybe you can sign for me.
Okay. So can you tell me that how much signature you need that for this OSET?
I need three signatures, as you mentioned, at least.
At least one should be with the consultant. Yeah.
Yeah, yeah,
Excellent, excellent.
yeah.
Yeah. So I hope you can do it properly, and I'll help you how much I can do it. Yeah.
Okay,
Okay.
okay, okay. Yeah, thank you.
Yeah. So I'll give you some episiotomy the materials. You can,
Mm,
if you want to know more, you can go through.
mhm.
Yeah.
Sure,
Okay.
sure. Yeah.
Yeah. And OSET form also, we can fill up this in the later on,
Mhm.
and I'll explain you more about that. Yeah. Okay.
All right. Yeah.
Thank you for your time, Uma.
Thank you. Thank you, Salma. Okay. Okay. Reflection, Dr. Salma, how do you think you have performed in this task? Hello?
Yes, actually, I just follow the, that teaching template,
Hmm.
and
All right.
because it is different, exam is coming different way, this one.
Hmm.
So, and now it is already, she has done, and on the only the instrument she couldn't handle properly. So,
Hmm. What else?
so this,
Anything else? This is are you aware of this question, by the way? It is
yeah, we have
has
done
some
that,
nuance.
the episiotomy that Apex couldn't find out, couldn't notice. That one we have done. But
Hmm.
this one, that it is different, that only that the instrument cannot handle properly. That's it. This is the difference.
There are some things which are different in this one as well, which are deficient, in fact. Okay. Can anyone point out from that? Anyone
Ma'am,
else?
shall I, ma'am?
Yeah. Who is this? Manikam? Yes.
Manikam, yes, ma'am.
Correct.
Ma'am,
Hmm.
that episiotomy, the angle is 60 degrees, ma'am.
Okay. One. Then.
Can I say, ma'am?
Oh.
Yeah, sure. Everybody
So
pitch
the
in. It's a very interactive thing.
the episiotomy was taken at the level of apex. Ideally, it should be above the
Hmm.
level of
Above.
apex.
Yes. Mm-hmm. Point number two. What
And
else?
I'm not sure that vicryl 30 or it should be like vicryl 20.
Either one is considered given in the strategy, so it's okay.
Okay, so
That's
that is okay.
right.
Uh,
What else? There are things which may be missing here, which may mean that it's not may or may not be.
And ma'am,
Sharp
actually the
and swab
submission,
count.
Okay. What else?
And do the parvaginal rectal examination before and after the surgery, before and after the episiotomy.
Right. hmm Okay, let's put now all of this together, okay, and solve the station. So now coming to your task, okay, whenever you are given something like when this task came, for instance, the information was given that there was a long description of how the episiotomy was performed by this candidate or this person, this specialty trainee sitting in front of you. And then in addition to that, they had like when you enter the station, what happens is if you read this question very, very carefully, you'll see that a lot of information is given, which usually happens in face-to-face. So um, you have domains which you have obviously gathered by this point of time. There is communication with colleague, which is an obvious thing when you're talking to a colleague. Then there is information gathering, patient safety, applied clinical. So there is likely to be some markings under each of these things. So that is the mindset that you're going in with. Okay. Now, the second thing is you read what is expected of you. Okay, what is expected out of you? Hmm? Task, so everybody will read, and most people do that repeatedly and carefully. My tip is to read what is expected out of you in the 10 minutes over and over, so that when you are going in the station, you don't forget what is expected out of you and start doing something else altogether. Okay, so this task will be pinned in front of you as well. You can take a look at it or glance at the fact what is written is expected out of you. Okay, and make sure that you are performing that particular thing to the T when you are inside and talking to the role player. Okay. Even structured discussions, they have some sort of a guideline provided, or usually they might have just answer examiner's questions. So those are, it is easier to get miscarried in structured discussions than compared to simulated patient tasks, wherein your problem statement or what you need to do inside is already provided to you in the form of do one, two, three, and you follow those steps and you should be through. So what is given? What have I written there? Give constructive feedback. One thing. So you're getting marks for giving feedback. Second, fill the OSAT form. Okay. Now there is a trick to this thing. You have to understand. So when you are face to face, you have to have good situational awareness. You have to look all around you. Okay. And the role player might be presenting you with one particular aspect of that thing. Like they may give you this particular OSAT form to be signed and say that I feel like my episiotomy has been done very well, and I want you to sign this OSAT form for me, which I displayed to you. Okay. But if you read the task, what is mentioned here is that the trainee has discussed with you to sign a formative OSAT form for the procedure. That is why when you entered the station, I mentioned that I feel now it has gone well, so please sign the summative OSAT form. Now, your answer is obviously to decline that request, but the reason for that is not because I have done badly or I have made mistakes in my episiotomy. Summative can still be signed if it is discussed beforehand, okay? That it needed to be signed. But you will sign as working towards competency. It is not that you can say, no, no, you've done badly, I cannot sign the form. No, that's not how it goes. If it is discussed with you to do a summative OSAT, but it has gone badly, what you will do is you will write here, trainee is working towards competency, okay, right? And you will write a feedback as to what really went well, what could have gone better, and make up a learning plan. Okay, this is what you do if you are signing a summative OSAT. In this station, you will not do that. Okay, you have to say, no, I cannot sign because as we discussed, we can do formative OSAT for you, which we previously agreed upon. Okay, unfortunately, it cannot be changed after you have done the procedure. So then pick up the form in front of you, which role player might not even give you. Okay, there'll be another form in front of you, which you have to pick out, and you have to say, this form we can proceed with signing. Okay, and you need to write down. All right. Dr. Salma, did you manage, like, did you write anything down? I don't think so because I think you didn't, want to fill a form in this station. But if your station says fill a form, fill a consent, okay, fill a prescription out, you need to do that because then they are testing your skill for correctly filling out this thing. That is where you are being tested. So as I go through the marking scheme, you will see how that is very, very relevant for you to understand how you're being exactly marked in this station. All right. Yes, everyone with me so far?
Yeah.
Okay. So as I said, you have to be very familiar with these kind of forms and understand what are the principles of good form filling in order to do these tasks well and be able to gain more marks in your patient safety and applied clinical knowledge. Apart from having knowledge about episiotomy, you need to know about OSAT. Okay. How would you ideally, in under ideal circumstances, start off with this station? The intro will be obviously slightly modified, right? Because you're familiar with this particular role player. You have been speaking to the role player, right?
Yeah.
Am I right? So,
Yes.
so you could, how could you do that in a slightly modified way? So, hi, I'm Dr. Salma, DST5. How do you do? Okay, that's an intro. I believe you wished for me to sign the formative OSAT for your episiotomy that I have observed. Is that right? So you're showing as a candidate that have that situational awareness, you've read the task well, and you have done your introduction properly as per what the task demanded. Hmm? So then next you move on to the role player is quite enthused. She was quite happy and very energetic, let's say. So she will say something like, I feel this has gone very well, and you sign, please, my summative OSAT, will you sign? So you have to say, yes, I really appreciate your enthusiasm, something, to that effect. Unfortunately, the type of OSAT that needs to be signed has to be decided beforehand, and formative cannot be changed to summative after the uh, performing the task. So, but don't worry, I can sign the formative OSAT for you. Pick up the OSAT form, all right? And ask permission for that and convince her and proceed. Okay. So then comes checking your background knowledge. So have you done any formative OSATs earlier? So she'll say, no, I have not done OSATs as such, but I have been supervised for episiotomies. Every supervision of episiotomy does not mean that an OSAT is filled, right? There'll be some which trainee will do under observation and then they will move to doing formative OSATs. After they are confident enough, they will come to doing summative OSATs. Then they will have 3 summative OSATs saying is considered competent at least by 2 different assessors, one of whom has to be a consultant. These are the rules. And then they are competent. Understand? Clear, everybody? Yeah, anybody wants me to repeat anything in this? Okay.
No, that's fine. Thank you.
Here. Then you move on to the next bit of the station, which is have you done and observed episiotomies before? Then they will state what they have done, not done before. Actually, why episiotomy and why OSATs are important? You need to put an emphasis for the subject matter which you're teaching in a teaching task always. So it is the most common surgery an obstetrician will perform. Therefore, it is a must to know it with expertise. Also about OSAT, formative OSATs are for you to your senior to give you feedbacks about your performance, and summative OSATs are to declare if you have competency, and you will need at least three summative OSATs signed by at least two different consultants to be declared competent, okay, to do it on your own. All right, then you move on. So let me put your name. hmm? So how you start off by filling the form? What do you think is the most important things to be filled in a form in this particular OSAT form? Yes, Dr. Salma?
Yeah.
How will you
Yeah.
proceed it? What serially do you feel is the most important, most vital information in this?
Yeah, first of all, we have to write the, the trainee name, what is written, that trainee
Yes,
name,
very good.
trainer name, then
Uh-huh.
which year he is grade, and
Yes,
date and procedure,
yes,
clinical details and competency.
right.
Then
So
after
first
that,
you will start. Yeah, yeah, go on, quickly.
yeah, then we'll write here that we'll show him that yes, checking that instrument and environment, so he checked properly or not. So in this case, he didn't check, but so here we can make it cross that he didn't check. And perioperative
Mm-hmm.
planning and positioning, this is okay.
Mm-hmm.
And
Mm-hmm.
technical ability, this is cross,
Mm-hmm.
because instrument not properly handled. And selection of the instrument and equipment, this is also cross. And economy of the movement, it is okay. Tissue handling, this is
Okay.
cross.
Mm-hmm.
Complement of the tags appropriately, completion of the tags as
Yeah.
appropriate, that is the cross.
Okay. Okay. Okay.
And communication with the patient and or relatives, it is okay. Then use of assistant, it is okay. Communication with the staff, okay. Forward.
Let me stop you there. It's not that you have to check this. This is not a checklist that you have to tick in filling this form, by the way. The form has to be filled not like you are ticking this particular list here, or you are ticking in. Let me display the formative OSET for you. So it's not that that is expected from filling the form. That is exactly what I want you to understand from this session. Is what essentially is form filling for an OSET. You're not ticking. It's not a ticking the forms list which is expected out of you. Okay. Firstly, this is the form that you will be filling, right? This is the formative OSET. Everybody is aware of formative versus summative, hopefully, right? So in formative, this is a feedback that is given to the trainee. Here, there is no pass or fail judgment. It is just, everything could have gone well also, but it's a formative OSET, right? You may not have anything that you need to give feedback on. You may not have any learning plan because everything has been going well. Hmm? But you still have to give a feedback. So it may be a positive, very positive feedback also, or very negative feedback also. Usually it's a mixture of both. But we don't expect you to take here. Okay, this list is telling you overall what all you may need to include in your feedback as you're writing the feedback. So the feedback has to be a written one, right? So you need to scribble a lot of things during the performance of the task, right? For which I would say now onwards, sit with your paper and a pencil to practice writing, because that's all that you will get in the exam. That is all that you will get. You will not even get a pen. So you have to take your writing pad of an appropriate size only. Don't sit with long books, because in the exams, you will feel that in unfamiliarity with compared to your practice. So that should not happen. You have to be very, very familiar with the exam environment also. Sit with your writing pad now. Now onwards, start using that with a pencil and do these kind of filling tasks as though you would do in the exam. Okay. So no ticking the boxes at all. So you, I would say, need to start off by writing trainee name, specialty trainee year, okay, and your name. Let me, you will say while you're doing it, you need to tell her, let me write your name, Uma, and your year one, and today's date. While I write my name and my grade is an ST5, right? You are the ST5. So write your name in this, and we'll write the procedure as episiotomy, and a simple one. Complexity was routine simple, right? So
Yeah.
meanwhile, I will put my signature here as the trainer. Okay, let me put my signature here. So you will make the sign first on the form here. Hmm? Then say that if you are happy with, provided that you are happy with the feedback, you can sign here, take their signature. Okay, right?
Mhm.
This is what you do. Because you wait till finishing the task, and sometimes what may happen is you don't reach the end of the task, which has a lot of marks. Signing the right boxes and signing this thing here, it will have a lot of marks for you. So you don't want to miss out on that. You understand? So
Right,
don't
right.
waste time with this. So you go there first, you say this thing to the trainee and say, okay, you can put a signature here as well. And then start writing. Okay, so let us look into what you have done correctly for this episiotomy. What could have been done better? Okay. Now, if everybody's seen the maternity pearls OSAT form, so specifically episiotomy has a separate kind of a OSAT because it's the most common thing to be done, and this data is taken from the maternity pearls OSAT. But obviously, the kind of form that you get in the exam will be this one. It will be this one. Okay, so
Right.
practice with this one. The pearls I'm just showing you because I want you to understand what all they include into filling of the OSAT, like what all you need to check out when you are assessing a trainee. You're an ST5, right? You've gone through all this. Now you are assessing another person, so you have to be very thorough with episiotomy and not miss out on anything. Correct? Hmm?
Yeah. Yeah.
So that is why you will first do that aspect of the form filling, and then you will move on to the feedback. Okay. So let me take you through that now. Hmm?
Let laptop be
Sorry,
your bag.
who is that? Okay. Someone is unmuted. I do not know. Now, so let me put your name, signature, everything, and all these things. And I see that you've selected the case for giving episiotomy well. Okay. So as she was a primary gravida with a rigid perineum, so indication is alright. So secondly, the patient was under epidural. Feedback means first, you don't start off by telling her, no, your instrument handling was not correct and you didn't guard the needle. No, that's not how feedback is to be given. It is always the positive things first. What have you done well? Always comes first. So, so you enumerate all these things. Now, in this particular scenario, it is preferable that you take her stepwise through, one thing after another about the episiotomy. So, secondly, the patient was under epidural, so you did check and took a verbal consent to proceed. That was really good. Then the episiotomy was given in a straight cut starting at the posterior foreshead at the time of crowning. All this is good. However, note that the angle has to be at a 60-degree on a stretched perineum so that when unstretched, the cut falls at 45 degrees. This will prevent any inadvertent damage and extensions to the anal sphincter and also ensure that the episiotomy is not too lateral to prevent cutting any blood vessels in the perineum. This is an added justification. You want perks, you want extra to impress the examiner slightly more. So you're justifying why you're taking a particular action also. So you're showing your knowledge to a trainee, correct? So that's also something you could include. Also, so in your filling of the form, this is not something that you will write. All right. So you will say, maybe you will write, scribble, cut given well, but in the what has not gone well, angle of episiotomy wrong. You can write that. All right. So next, also, it is always prudent to take account of the instruments and sutures and mops kept on the trolley and ensure that all your instruments like the non-toothed forceps, needle holder, sim speculum, scissors, okay, cord cutting scissors, arteries are handy before giving the cut. Okay. After the delivery, which was conducted well, AMTSL, active management of third stage, was also offered. This is appreciable, and you did do a visual inspection of the perineum, okay, but it is recommended you should perform a palpation of the perineum with a per rectal assessment after explaining to the woman and taking a consent. Okay, you see how many points are getting covered as you are explaining, right? Consent is another point, PR examination is another point, palpation of the perineum is another point, right? So as you speak, all right, you are explaining as well as certain things you are able to write down, and you are ticking your boxes as you move through the station very smoothly. All right. So this is so that you do not miss any injuries like a buttonhole tear, which are not visible very easily. So I noted that you asked for the right suture material and proceeded. That was good. Also ensure that the epidural is still acting for pain relief at this stage. Otherwise, we may have to give local anesthetic. Hmm? So, you know that after the delivery, again, you have to check for analgesia, right? That is always told. Hmm? Always check for whether analgesia is needed or not. Then, for the apex, instead of starting at the level of the apex, we advise to start about half to 1 centimeter above the apex so that the vessels do not retract or cause hematoma formation later. And ensure that a non-toothed forceps is used to handle tissues. Okay, because what is mentioned, toothed forceps was used by this person. Another point. So, and a surgeon's knot is made about half centimeter cut is remaining behind at the time of suturing apex. So you started suturing mucosa and did it under vision, adequate depth at half centimeters distance. This is good. You must ensure that the width and the depth on either side also match and the alignment of the mucosa is correct and it is sutured continuously, achieving a realignment of the hymenal ring. This is the final outcome expected. Plus, when you started suturing with the mucosa, while suturing the perineal muscles, at the first, the needle is inserted deep into the muscles, matching the width and the depth using continuous inverted method, and all the dead space is to be closed. Okay, this is another very, very vital patient safety point about dead space. Okay, ensuring that the last suture emerges at the apex. You have closed the muscles in 2 layers. That was done well. When we come to the skin, always ensure that the sutures are placed subcutaneously, directly opposite, avoiding puckering, and you arrive at the level of the hymenal ring and secure an Aberdeen's knot. So you have done these things well. That was good. And also, I recommend that you check for bleeding, do a vaginal examination, per rectal examination to look for any stitches having gone through the rectal mucosa and ensure that the swab and instrument counts are checked. Do an estimation of the did an estimation of the blood loss. That was good. You documented this again. That was good. So let me write down what you have done well in this box here, and I recommend the following points which I have mentioned and in this box here. Okay, so this is how you take one by one. You will have to practice writing slightly faster. Not that all these points that you are mentioning will come. You will have to mention at least three, four points on either what has gone well, what could have gone better. And then in the end, another essential thing is it is also important as a part of learning to reflect on your own tasks or your own procedures that you have performed. That means you can write what you feel about this and how you intend to correct yourself or improve your performance in the future, so that you can mention it here. So you tell the trainee to fill that. Okay. So they will not write down obviously for you, but it is your instruction about this and the awareness of this, and the fact that you have mentioned this in the station, that's what is going to get you marks. Okay. Hmm? No matter how the station has gone, do not ever in teaching forget to signpost for further learning. It is always a point which is going to be marked under patient safety. So, say about online tutorial strategy videos, demonstrate on the mannequin, ask how the session has gone. Well, and say that right now we will do this, and subsequently, if you want summative OSAT with me after you've done adequate practice, we can go ahead and do that for you. All right? All right. Okay.
Yes.
So a lot of points, a lot of points which are there in this station. Not as straightforward as it appears to be while doing it. Um, in these kind of stations, the level of expectation that an examiner has from you as a performer is going to be higher. The reason for this is very simple, because episiotomy is an everyday task, and you're supposed to be the best at it. Okay, and you even if you forget patient safety points in this station, usually not condoned very easily. Might have very severe repercussions in terms of marking if these points are missed. In this, information gathering was a very easy thing to do. You can directly straight away get a 2 in this by just asking about the ideas, concerns, expectations, what do you want from today's session, that's all. And asking about ruling out bullying, all these basics, if you do, you can get. But in this, to score well in patient safety and applied clinical knowledge will be slightly more tricky. There are stations where you have lesser number of PS points, more number of information gathering points, a lot of simulated patient task work like that. But in this particular task, it's kind of the other way around. But yes, information gathering is being marked. So you can easily, the lesser number which is there in the task to be marked under a particular domain, in fact, means that you can easily lose marks as well in that domain, right? So if you do not ask one question, or if in communication with colleagues something goes amiss, right? So you can end up spending marks there. Okay. So you can take a look at how the domain-wise key is for this as well. Alright. So chunking of your information, repetition of anything which you did, appraising when I say something good, gathering feedback from me, using medical jargons are acceptable, correct but do not undermine, and encouraging non-threatening, your eye contact, body language, everything will be tested. Just be little smiling and happy with the role player, and keep them a little more engaged. Okay. As we said, we
Hello,
have
ma'am.
covered all of this.
He-
Yeah. Yeah. Hi.
hel-
Who's this?
Hello, ma'am. Ramya.
Yeah. Hello. Ramya. Yeah. Tell me.
Regarding ST, being an ST5, if
Mhm.
pre-declared, can we sign the summative OSAT?
Mm, actually, summative OSAT ST6, 7s can sign, but for simpler things like in practically, you can. For episiotomies, which are very straightforward, you should be able to, but you need consultant at least, one in the three that you are declaring. You can, but such a station has so far not come in, not come up also. There is no fun in that station at all. So,
Okay.
uh, so this is what the trick in this station is. So yeah, Salma, so Dr. Salma, sorry, little more careful.
Yeah, thank you very much for your feedback.
Yes.
And let me to allow.
Yeah, no issues, no issues. So, Who is the next person
Can
that we
I
are?
ask
Any
you that?
questions in this?
Yeah.
Yeah, tell me.
So what you mentioned that the trainee, what he has done right way and wrong thing. So in the form, I don't need to the mention about that.
You do need. You can mention like 3 points under each, like each very fast. You'll have to write down. Right?
No,
That's why I'm telling you to
can you
practice.
show? Can you
Hmm?
show it this form that in this
Yeah.
case what will
Hmm.
how you
I'm not filled in a form for you here, but I can show you the form. Like you would write this. See, this part is the most important. This
yeah
one
yeah
and this one, trainee signature and trainer signature.
okay
After that, you'll say, okay, we will do and start giving your feedback. While you're doing the verbal feedback, you will mention a few points here. Like I feel that you have gave a good cut, maybe. Okay,
hmm
but angle of episiotomy wrong. You will write down. Okay, then
yeah
yeah, that way. So you will make a mention of each of the things that you are mentioning, apart from what you mentioned about positioning or
yeah
handling of the needles, or use here you will write, say for instance, you will write use toothed forceps. That much is enough. Three. You don't have to
yeah
write long sentences.
okay
Just points, points, points. And that similarly, as we see now in the next few forms, also we will see how we can write down in a very brisk manner that you need to
okay.
mention this thing. Hmm?
Learning plan also we have to write
Yeah,
here
you can
learning
just mention one word like strategy videos, and
okay
that's it. Supervised epi. Enough.
but
So they are not going to take you're getting marked in real time, no dear. So what you have to understand is once you have done that task and you've moved on, in the next 2 minutes you are being passed or failed in that station. Okay. Handwriting, yes, is like it should be legible. It doesn't have to be beautiful handwriting. So you don't take time in writing it in a very slow fashion, or writing it very, very nicely. Not required. As long as it
okay.
is readable and smooth, it should be fine. What the
hmm
examiner don't make wavy lines and walk out, which nobody can make out what it is. As long
so
as it
same
is readable, it should be okay.
so same time while I'm explaining, so I have to write here everything
Yes,
and
yes,
then
yes,
I'll
yes, yes.
sign, then you also sign.
Yes, I'm
Yeah.
not saying make the list very exhaustive, like all the points that you've mentioned here. You need not, but you have to speak of all the points. You have to
Yeah.
mention a couple of points which you would choose, like say your angle of the thing,
Yeah. Yeah.
using the toothed forceps, handle
Yes.
the this thing, guard needle. You can write
hmm
didn't guard
Yeah.
needle. It's in 3 words, no? It's
3 words.
easy
Yeah.
to do.
Okay.
So don't practice it. It won't come to you naturally. It will not come.
hmm
First time you go to do it, you will definitely not.
hmm
But then as you practice, you will be able to. Don't worry about that. Hmm?
And no need to what I told tick mark. No need to that the form. I'll give this
Hmm?
what he has done and what I was thinking that it will be, that I have to tick there. So no need. Thank you, Dr. Uma. Hello, I cannot hear him.
Hello?
Yes, now I can hear you. So what I told that to give tick mark that yes, you have done this tick, this is cross, so this is no need. What I have
No, no,
done
no,
wrong.
no,
Yeah,
no,
thank
no,
you.
no, no,
Thank
no,
you.
no.
Okay,
That's not.
thanks.
Okay. Sorry, I'll not be able to put my video on for the next one because my lights are gone, so I'm connected via a different network. Okay.
Thank
So
thank you for nice explanation.
yeah, no issues. Yeah. So who's my next volunteer?
Shall I do, ma'am?
Ramya. Yes, definitely.
Yes, ma'am.
Okay, expect different things today because it's face to face and we're preparing you for everything. So, mm, all right. Let me just share this. I'm audible properly, no? Is my voice is breaking or anything?
No, you're audible. Yeah.
Okay, good. Starting your time.
Shall we start? Hello.
Yeah,
Hello.
okay, can start. Hello, yes, can
Uh,
start.
yeah. Hello, I'm Dr. Ramya, one of the doctors in the clinic today. May I confirm your name and age, please?
Yes, I'm Juliana, I'm 23.
How may I call you?
You can call me Juliana.
Okay, Juliana, I understand that you are here to discuss regarding the sterilization procedure. Am I right? Hello? Hello? Hello?
Yeah, that's right.
Uh, uh, you here?
Hello.
Hello, you are here to discuss regarding the tubal.
Hello. It's not able to
You
hear
are
you.
here to discuss
But
regarding. You're not able to hear, ma'am.
hear you.
Hello?
Can you please speak up now? I was not able to hear you.
Yeah,
Sorry about that.
yeah.
Yeah, okay.
Hello?
So I'm restarting your
Uh,
time because you've just done introduction. So
okay.
let's see that. Hmm. Start.
Hello, I'm Dr. Yeah, yeah. Age, please.
Yes, I'm Juliana. I'm 23.
How may I call you?
You can call me Juliana. It's fine.
Okay, Juliana, I understand that you are here to discuss regarding tubal ligation. Am I right?
Yeah, that's right.
Yeah. Juliana, since we are meeting for the first time, can I ask you a few more questions, then examine you, then tell you about the procedure and further plan? Is it okay with you?
Yeah, that's fine. Yeah.
Juliana, can you tell me more regarding concerns?
Doctor, I know that I don't want to get pregnant ever, and I wanted something permanent. So I was looking up for solutions, and I found that I can have my tubes tied, and that will, solve my issues altogether. So that's why I'm here, and I want to learn about all this and go ahead with it.
Okay, Juliana, may I know the concerns behind getting a permanent method?
Well, like I said, I don't want to get pregnant ever.
Okay, okay. The Juliana, how about your cycles? Are they regular?
Yes, they are.
When was the last period?
It was about 1 week ago.
Okay, and have you got HPV vaccine?
Yeah,
Yeah. Okay, and some of my questions might find very intrusive, and
mm,
also I would tell you that whatever we discuss here are totally confidential. You can be comfortable to talk to me. Okay.
sure.
Any pregnancies in the past?
Well, actually, yes, I did get pregnant, and it was not a very pleasant experience. And the first time around was when I was 18, and I used to use condoms, but it had burst, and that time I conceived, and I had to undergo an MTP because I didn't want the pregnancy. But after that, I started using the pill, and that also I cannot keep track of it. I keep forgetting the pills. I got pregnant again last year, and that resulted in an ectopic pregnancy, which was in my tube, and it burst, and it was so traumatic. I almost, lost my life. Plus, losing a baby was, very. It has scarred me. So I don't think I can ever go through with any of those again.
I'm so sorry for that. How are you coping with this? Have you been across any counselor?
Not really. It has been difficult.
Okay, don't worry. Uh, Juliana, do you have any medical illness?
No,
Any surgeries other than the ectopic and the
no,
abortion, the DNC?
no,
Okay. Any known allergies?
no.
Your blood group?
It's B positive.
A reservation for blood transfusion?
No.
Juliana, your weight to height ratio?
It's a 22.
Are you on any medicines?
No, nothing.
Do you smoke, drink alcohol?
No, none of that.
Okay. And Juliana, whom do you stay with?
I stay with my boyfriend.
Okay. And how is the support?
Yes, he's quite supportive.
Okay. And what do you do for a living?
I am planning to, I'm a pre-law student, so I'm going to do that.
Okay, okay, fine. So, of late, how has been your mental health? Have you felt down, depressed after all
Like I
this?
said, this has been a very traumatic experience for me, but I think if I get this the procedure and that solves this worry of mine of getting pregnant ever, then I should be doing better.
Okay, Juliana, thanks for all the information you have given. With your permission, in the presence of chaperone, can I examine you, take your heart rate, blood pressure, check your tummy, and also down below? Is
Sure.
that okay with you?
Yeah. Hmm.
Yeah.
Sounds okay.
Okay, fine. Yeah. Juliana, your concerns are totally valid as you have gone through a lot of things. I can see you're disturbed with that. Don't worry, we'll help you out at the outset. But Juliana, as you told, this sterilization procedure, it is not, that is nothing but the tubal ligation which I was talking about. Do you know about it, how it is done, and what are the associated?
No, 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 not really. No.
Yeah, yeah. Basically, it's a keyhole procedure where usually small nicks are made in your tummy, and we go through the camera, visualize inside, see how I mean, see the tubes, and put small clips, or usually the clips or bands are put over there. And meanwhile, if any other problem is there, that will also be documented and come off. And usually, this is a permanent method. So
Mm.
the thing is, the advantage is that you will be getting rid of the problem of pregnancy which you are having for as a permanent solution. However, in our clinical practice, we have seen that people who come with this with the age less than 30 years, we see a lot of regrets among them. Are you getting me, Juliana?
Oh, is it? Uh, but
Yeah.
doctor, I feel like I'm not ready for another pregnancy ever. I'm quite sure about this.
Okay, your concerns are fine, but there are also other methods, Juliana, which if you want, I can explore. They are not the permanent ones. So as and when, see what happens usually when they come early before 30. At times, when at a later date, when they want to have a baby at a later date, then if we go for channelizing the tube or canalizing it, so at that
Mm.
time it
Mm.
may not be successful. Okay, and also at times the procedure is not funded by the NHS. the success is also not quite good. And this being a surgery, it comes with its own risk, like quite frequent risk, like injury to the surrounding structures and the vessels there at times, and some remote risk like hernia at the site. All those things can happen. Are you getting me, Juliana? So if you
I
want, I can
see.
talk to
Okay.
you about. Would you like to know about the other
Yes.
methods?
Mm-hmm.
Yeah,
Yes, you could
yeah,
tell me if there's anything.
yeah. Here, yes, yes. In this, we have certain inserts, that is the plastic tube-like thing which has copper in that, and which can be put inside the womb. That is the insert. Then we have implants, okay, and also we have certain injections. These are usually for they come and act for a long time. In the inserts which I told you, which can be placed inside the womb, we have one is the copper, the other one is the medicated one. Medicated one we call as Mirena. Okay, so this
Hmm.
usually the yeah, the copper usually it requires like in the OPD only we can put this. However, it causes little discomfort, and at times it can cause injury to the neck of the womb, and sometimes infection can happen. Anything in specific you would like to know, you are looking for?
Uh, well, yeah, this now that you mentioned, what is its benefit over the operation?
Yes, the thing is, this can be removed whenever you want to become pregnant, and immediately
Uh-huh.
most of the times you'll get your pregnancy back. So it is like the advantages, you can pull it on as long as you want. Like usually copper can be kept for 5 years or 10 years depending on the life,
Mm,
and
mm,
also the efficacy, that is how effective it is. 99% effective out of 100 cases. Okay,
mm,
and also
mm.
you need not remember anything, like once placed you won't have to worry about it. So that's the
Okay,
advantage.
Atil, yeah, you can tell me more about this coil.
Yeah, the coil, usually the pregnancy rate is only 20 out of 1000. So otherwise it is a very good long term active one. And then after insertion procedure, little discomfort as I told you might have, and after every period you may have to check the threads, and if you don't get the thread, then you can get back to us on our contact number.
Okay.
Okay, so mainly
Mm,
it
mm,
acts mainly by releasing the metal, that is copper. Okay, so since
mm,
that prevents the sperm from fusing from the egg, and then
mm,
prevents the pregnancy from happening. And also sometimes pregnancy can it avoids the pregnancy from burying inside the womb. So since I've given
mm.
a lot of information, I'll give in patient information leaflets on this. I'll fix up your appointment with the consultant as well. So you can go through them and get back to me. If you want, I can
Okay.
connect your cross counselors as well.
Mm-hmm,
Yeah,
mm-hmm, mm-hmm.
thank you.
Okay. Yes. Ramya, yes, reflection.
Yeah, time,
Time. Okay.
time. Um,
Or,
should have
or
been. I should have explored your but should have.
yeah, tell.
I mean, ma'am, actually, I was not knowing where exactly to take the station. Like it was which direction you
Confusing.
wanted it.
Okay. No, but
Yeah.
role player was acting as what was expected from the script, right? So I was no at no point of time there was any misguiding done from her. This is what she wanted because of her agenda, which was that she wanted to discuss sterilization. So you need to start off grasping from that point itself. Okay, this you have to realize becomes like a negotiation station, just like how we have patients in labor when we are negotiating with them.
Mm,
This is kind of on the similar lines as is because I thought that you were going in a completely of a direction, okay, and taking her towards probably sterilization. And you started coming towards larks and why, what is the advantage of larks towards the very end of this station. Maybe that is why you ran out of time,
okay.
right? So,
Yes, ma'am.
essentially, in this, if you realize, if you see that what your task is, Kavya is unable to hear. Um, is everybody else able to hear?
Yes, we
Yes.
can hear you.
Yes, ma'am.
Yeah. Okay. I think check connection should be the one. So essentially we'll do one more of this. I need another volunteer, and then we'll come back to the feedbacks. Right? Hmm? Let me see. One more person with a pen and paper.
Can I do?
Who's this?
Hello.
Dr. Sadia Firdaus. Yes. Yes. Okay. Similar one. So I'll just give you a minute or so. This is just practice. Do not worry about it. Hmm? And there is one more slide in this. Dr. Sadia, you can see, right?
Yes, yes.
Yeah. Let's start that. And we will do a comparative analysis. Yeah. Yes, you can start.
Mm-hmm. Hello, I'm Sadia, one of the doctor in the clinic today. Can I confirm your
Uh-huh.
name and age, please?
No, I'm Juliana. I'm 29.
What would you like me to call you?
You can call me Juliana. That's fine.
Okay, Juliana, I gather information from your notes that you are here for the procedure sterilization, and I will just let you to be the through the consent form and tell what is the procedure, what is the benefit and risk associated with it. At the end, if you are willing, then you will sign in this paper, and I will also sign at the end of the consultation. Is that okay, Juliana?
Yes, sounds fine to me.
Okay. So, can you tell me that do you have any complaint?
No, I don't have any complaints.
Okay. And may I know that how many children you have before?
I have two kids. They
Mm-hmm.
are 6 and 7 years of age.
Mm-hmm. And do you know that it's a permanent procedure? You will not be able to get pregnant after this. That.
Yes, I am.
Mm-hmm. And how is your period, Juliana?
Periods are quite normal, regular.
Mm-hmm. When was last period?
It was about a week back.
Mm-hmm. And are you using currently any contraception?
Well, I am on the using the condoms on and off.
Mm-hmm. Okay. Any unprotected intercourse in this cycle?
No.
Mm-hmm. And are you up to date with your smear?
Yes, my smears have always been normal.
Mm-hmm. And any medical condition you are following with your GP?
None.
Any surgery in the past in your tummy or down below?
No.
Mm-hmm. And may I know that about your deliveries? Is it normal delivery or the cesarean section?
Yeah, both were normal deliveries, and there was no problems at all.
Mm-hmm. And are you in a stable relationship?
Yes, I am.
Mm-hmm. Any
I'm
drug related to
married.
that? Mm-hmm.
No, no
How
allergies.
is, mm-hmm. How is the support at home?
I'm very well supported.
Is your partner is familiar about your decision?
Yeah, I will discuss with him.
Mm-hmm. And are you know that any alternative than the sterilization for the contraception? Anyone discuss with you?
Well, yes, the consultant in the last meeting had kind of discussed, offered me other options. But the thing is, I cannot tolerate hormones. I get very bad bloating with it, and my breasts hurt, and I get headaches and all of that. So I declined all that. And I've been using condoms, but there is slippage and all of that, and I have to take emergency pills at times. So I'm not looking to get pregnant in the future. Therefore, wanted to go ahead with this.
Okay, so are you familiar that when the any reversal of this procedure is not funded by the NHS in the future, if you want it?
No, I was not aware of that,
Yeah,
but
this is
that's
a
okay.
permanent. That's okay. Okay. Some of the regarding your social life, do you smoke?
No,
Take alcohol?
no,
Take alcohol?
no, no.
Are you aware of your height and weight ratio?
It's 24.
24. And about your blood group?
It's B positive.
Any objection on the blood transfusion if need arise?
No,
Okay. So anything else you want to add?
no, nothing in particular comes to mind.
So I will review your notes also. And any blood test done? Uh,
Yeah, we've given the blood for investigation, not yet.
any pregnancy test done?
Yes, that was done last time. It was negative.
Okay. My midwife will examine you, check your pulse, blood pressure, temperature, and I will examine your tummy. So is that okay for you?
Yeah, that's fine.
We take the swab from down below too to rule out any. So
Okay.
first of all, this is the procedure. It's a keyhole surgery, and in this procedure, what is the benefit? We said it the blockage of the tube to through the procedure. We said is sterilization. The benefit of this procedure is that you will not be get pregnant. It's a permanent method. Okay, this procedure is a but every procedure has some risk. Okay, so
Okay.
let me explain you some frequent risks are associated with this is that you might be having the infection for which we will give you the antibiotic to avoid it, chances of having the bleeding, okay, and you have might be some shoulder tip pain after the surgery and some bruises at the type of where we will put the camera, okay, some
Okay.
long-term complications, bruises at the side where we give some cut.
Yes, yes. Okay.
And then long term might be you have some hernia at the site of cut or after that, and due to the anesthesia complication and few complication regarding that due to the surgery, the blood clots in the lungs and legs, but we make sure that you will be followed by the enhanced recovery program to avoid all these complications. Am I clear so far, Julia?
Yeah, I understand.
So what we will do in the
Yeah.
procedure, the anesthesia doctor will be put you in sleep. Then after that putting you sleep, we will examine you. Then we will give a small cut at your belly button and pass a camera to that. And at that time, we examine all your womb and ovaries and your tubes. And then we will ligate the tube. There are different methods to be block the tubes. Sometimes we put a clip. Sometimes we will put a thread and cut it and burn it. So it will be depend upon that which procedure we will use. After ligating your tube, then we will give the procedure after completion of the procedure. Okay, you will be discharged on the same day. We make sure that you will be pain free after the procedure and early mobilized, well hydrated, and then after when you're able to be eat and drink and pass your wind and urine, you will be able to go home. But during the first 24 hours, Julia, we advise you not to take any decision because you might be little dizzy. And there's a chances that you will not be able to drive. So it's good to be someone with you at the day of surgery to drop you at home. Am I
I
clear so
understand.
far?
Yes.
Do you have any questions so far?
No, not particularly.
Mhm. And after the procedure, you gradually come back to your daily activities and take the shower after 24 hours and
Okay.
take a healthy, balanced diet, plenty of fluid. If you feel that you have the stinging urine, pain during passing urine, you have
Mhm.
unusual pain, which is not controlled by the pain, simple medication, or you
Mhm.
have shortness of breath, leg swelling, fever, feeling unwell,
Mhm.
in that case, we will give you 24-hour emergency number. You can come and contact there.
Okay.
Okay. And you can go to
Mhm.
your work after when you are ready to go. If you have a light work, you can go back after 2 to 3 weeks. Usually it takes 6 weeks to be recovered completely. But mostly after 3 weeks, you can go for the routine light work activities.
Okay.
Okay. We advise you to be use effective contraception until you have your next period. Okay, because you're not using any contraception. Use the protective measures to avoid to have any other pregnancy until this tubal method will be worked.
Okay.
Do you have any questions so far, Julie?
No,
Would you
nothing.
like me to repeat anything?
Are there any other risks that I need to be aware of about the procedure?
Yeah, after this procedure, if you delay your period, in that case, we will advise you to do the pregnancy test. If it's positive, come into the emergency, because after this procedure, the failure rate is there, 1 in out of 200. And if the pregnancy occurs, it will be outside the tube. We said it ectopic pregnancy. It might be the life-threatening condition. So we report you to be advise you to be reported in the emergency after
Mhm.
having the pregnancy test positive.
I see.
I will give you the patient information leaflet regarding the sterilization. If you are willing to go ahead with the procedure, I will sign here and you will sign at the end. Is that okay, Julia?
Yeah, sure.
Okay. I will meet you in the theater. Okay.
Sure.
See you
Yeah.
in the theater with my consultant. Okay. Thank you.
Thank you. Yes. Time is up. 2, 3, 1, go. Okay. So, reflection? Anything? Show me what you have written in the paper in front of you, as they requested. Hello, Dr. Sadhya?
Yes. Hello. Yes.
Can you show me what you have written in the page which was there given to you?
No, I did not write too much about the history only. I wrote.
Okay. No, I meant to say when I started, right, I had asked you to keep the paper and assume that you're filling this particular form, right, as you're doing the station. So what have you written down?
No, I did not write about that one. Sorry, I did not get your instruction at that time.
Okay. Uh,
Mhm.
well, yes. Okay. So this whole thing was about practicing to fill the forms, anyhow. But okay. Do you feel that there is anything that you wanted to add or do differently in this station? Anything more
Mm.
that you wanted, perhaps, which you feel RCOG will mark instead of marking some other things that you mentioned in this?
Mm.
Hmm?
About her any abuse?
No, not really. Why? Because a happy role player who's, speaking very nicely to you. Why would you suspect her? He was
Mm-hmm.
not an unhappy person. Nothing was happening of that sort. All right. Now, maybe let me ask everybody about what they feel was the difference in the way the two questions were asked. What was the difference in the questions? Did you notice? And how did in the first, Dr. Ramya went to do a negotiation with her rather than you going directly to the doing a consent signature? Okay, so the main difference, if
Age,
you note, age is one.
age,
Yes, it's a clue.
parity,
Age is a clue.
parity.
Yeah. Okay. What else? What is the
and
question?
and
How do you
also to
know? How do you avoid getting confused what you need to do in the task? What did I say in the beginning of the um, this session today? Okay.
Uh,
Read what is given here. Read what is given, what is expected of you in the 10 minutes. Okay. Read the task now again with a new perspective. So
Ma'am, in
what do
the
you
first
see?
question, it was just to explain, explain the procedure. In the second, we are supposed to take the consent as well. While taking the history, we are supposed to write down the consent as well.
Yes, okay. So this is what the second task states. Take relevant history, take a well-informed consent. So take a consent. They are telling you outright. Don't get confused between what is expected. Even if she was 25, 23, whatever she may have been, if it is the additional thing is provided that this is somebody who has had a discussion with the consultant previously, so it is just, you need to take a quick history, clarify what is discussed, what her background knowledge is, why this discussion or why this decision has been reached, and then go ahead with doing a well-informed consent. Answer any concerns if she has. This is what you are expected to do in this task. Let us go back to and take a look at this question, which says, take a relevant history, answer her concerns, and make a safe management plan with the patient. Now, safety includes looking into the mental well-being and psychological well-being of the patient and what will be the best possible options for her as well. If in this patient you end up agreeing for a sterilization, that would be considered reckless endangerment of the patient, right? So you would fail in patient safety if you did that in this particular task. Okay. Now, there were some things though, which I think in your situation, Dr. Ramya, for instance, when you started, you were going very slowly and cautiously towards how, because you were a little bit confused or how exactly this task was going to proceed. And do not set a very long agendas right in the beginning of the station. So I'll explain to you exactly why the running out of time happens in any tasks is because initially there is some amount of time wastage which is done in probably say everyone is used to asking double questions like may I confirm your name and age, then second question for what would you like to be addressed as. Can you not just ask that in one go itself, like what would you like to be addressed as? I am so and so, what would you like to be addressed as? And then proceed with the rest of the station, which is age, etc., etc. Okay, age, what do you do for a living? And then proceed. I have gone through your notes, or I have gone through your GP letter. I have gone through your reports, whatever she's come to discuss. No need to say that I understand all these things and let me do examination for you. I'll take a history, then I'll do examination, then I will make a safe management plan with you. Aren't you going to do that in the station and display that you're doing it anyway? That shouldn't be the way that you do an agenda. I know it's a very annoying habit, and most people have acquired it. Get rid of it. Okay. You can save some time, and you can directly go towards that open question, and then they will state a problem. Okay, they will say, okay, tell me, okay, this is what it is, and I've seen your reports. Can you tell me more about your problem? Then she will say something. At this point, you can point out and say, yes, I need a couple of more questions from you. Then I will address your concern. That is agenda. Okay. So it should be smoother. Even the way the communication goes becomes smoother if you do not do it in that particular fashion. Okay. So second is about, I think you asked me about vaccines. Was there any particular reason why? HPV
No,
vaccine.
ma'am. She was trying to, instead
Just
of
okay.
smears,
Fine.
just ask her.
Smears, she's 23, so not. But okay, you replaced the question. I see. Is that what happened? Okay, so
Yes.
it may not be so important. It's not wrong to ask. Yeah, okay, but it wasn't getting marked for you as such. I was just wondering why that came up. So, secondly, now in this situation, one very good job that you did was you asked about the explored the agenda, which is the hidden agenda. The patient doesn't, volunteer this information as to why exactly she wanted a sterilization. She just keeps saying that, no, I want permanent, I never want to conceive, that's why I want to do. So later when you ask about the pregnancy and she tells you, and you assured her about confidentiality and all of that, and you were a very warm doctor to her. She opened up about how she's had traumatic experiences from using, having failed contraceptions before, and then going to um, getting pregnant, which has been very difficult for her. Now, red flags immediately should come up. It is not enough to ask whether you have been seeing counselors, and then she says, no, it's been difficult for me. Immediately your next line has to be, I will suggest counselors. Understand? So
Oh, okay.
moment you do that, you're ticking another box. You realize what happens. Towards the end of the station, if you forget to mention the counselors, then you that box is unticked now. So you're losing marks.
Okay.
Hmm? So that should not happen. So moment this thing happens, you tell her she's not been seeing counselor. I can arrange. I can see how difficult it has been for you. So I can arrange for somebody to see. As such, your communication is not bad. You're doing a good enough job in that. You're smooth as well. There is some, Dr. Meenu, some disturbance. Hello. I'm just going to mute this. Uh, 1 second. Okay. Hmm? So, where was I? I was at how you go about talking to this. So, basic framework for this would be like what I have displayed here is phrase the sentences a bit more carefully, not to offend her, and primarily after your history, which should include the following, which is begin with an open question, explain why her decisions are as they are. Successfully explored the hidden agenda, no problem, tick this one. Pregnancy and its complications were asked, details were asked of the same. Past history of medical disorders, other surgeries apart from this, asked. Allergies, smoking, all these things. Currently, who you are with? She said, yes, boyfriend. And if you are going to suggest LARC methods or others, okay, in that station, it is very important to see that there are no contraindications for it. Like when I say I want to proceed with copper coil, at that time also additional history can be taken. Like, do you have any current history of any discharge from down below, any abnormal bleedings, contact bleedings, etc. Are you with me, Dr. Ramya? Hello?
Yes, ma'am.
Yeah,
Yes.
because you will be suggesting this form of a contraception, so you have to make sure tomorrow she shouldn't end up in some complication because of what you have suggested, right? So that is the thing. In addition to
Yes.
that, there'll be others like which you asked, your menstrual history, LMP, and when was the last unprotected intercourse? What contraception is she currently on, if at all she's using any? And if she's with a partner, that whether he has any children which he's raising, that also it would be an additional. These are finer points. The most essential thing would be ruling out contraindications to the management options that you are suggesting. Okay, that is important. Hmm? So you
Okay.
did ask me about any other contraceptives that I have tried. Okay, explore the knowledge about other methods. Okay, is she aware of any other methods? Now I'll tell you the crux and how I would have agreed with you more easily. Okay, can you think of any trick which will help in this? Now the negotiation begins, right? Your history is done. Negotiation is about to start. So
Yes.
how can you try and possibly bring her to understand your point? What is the one thing?
What are your views about having kids in the future?
She mentioned that, no, outright she said in the beginning of the station itself, she doesn't want any pregnancies at all. That's her mindset
Oh,
right now. So I'm telling you, I'm this woman who
After
does not
in
want a
the
pregnancy. What do you do?
in our clinical practice, with our experience, we see that many people who undergo this procedure later come in the future with the regret, wanting to get it recanalized.
No, that you told me already. See, you told me this. So I will then say, she will keep countering, saying, no, doctor, I told you I'm sure about this. Then you will keep going in loop, saying that, no, regret will happen then. But I didn't drag that point. That's different. But you cannot start off by convincing her about the regret. What does she want to hear? What will she want something permanent? What is her mindset about
We
this?
we can we can
Her
give you
mindset.
other forms of
Yeah.
contraception. Yeah.
No, I don't
Other
want. I have
forms of
made up my
contraception
mind. I
rely.
made up my mind. I want permanent only. I don't want temporary. I told you I don't want to conceive. Now what?
We can provide you long-acting ones, which will like the
No,
failures last time.
I told you
You
I'm
don't
sure that I
hear
don't
the
want to conceive.
Can I add?
Can I
Ma'am?
something?
Yeah,
Failure
sorry.
rate, I can
Yeah,
tell you the failure rate.
exactly. So this is what you have to see. This patient thinks that when she is getting ligated means that it's done. She'll never conceive again. So what is the thing you need to tell her is that despite this, okay, I have to give you all the information about everything. Don't worry, I'm on your side. I am here to help you with all the information. You make your own choices. Of course, we don't force anybody. Okay, we don't force anybody. But I want to give all the information. May I proceed? Okay, that's how you go. So it's a negotiation. So she's obviously she has to say yes. Okay, proceed. She can't say don't talk to me about anything. No, that's not going to happen. Moment she does this, you have to say that yes, what I agree about this ligation is what we do is we close the tubes using either clips or current method, whatever we use, and that doesn't allow the sperm and the egg to meet with each other because we are closing the conduit. It is considered as a permanent method. It is considered as a permanent method or a permanent solution, yes. But still, despite this, we have seen that pregnancies can occur. And then you utter the failure rates. Okay. Or she'll be like, oh my God, this also can cause pregnancy. So what? Now I was not aware of this. Then say, yeah, along with this, you have to. Now, there is only one advantage. I always say pros first and then cons, right? With the pros of sterilization, you just have one that it doesn't require an additional contraceptive to be used or remembered to be used after it has been done. That's the one pro of it. Apart from that, everything else is a con if you look at it. So it involves a surgery. One is failure rate, second is involves a surgery in order to go. So you can talk about that and talk about how and what are the effects of the surgery and what complications can occur. I would say use one sentence, practice using that one sentence which you would be utilizing in order to get your point across, okay, in these situations. So, sorry. One second.
Ma'am, ma'am,
Yeah,
it
yeah,
is
yeah.
not it is not preventing from sexually shared infection. That also we can say.
Yes, yes. Of course, of course. So, sorry, my throat is a little okay. So, where were we? Yeah. On the other hand, it is that although it is considered as a permanent method, you must be sure about your decision. In addition to that, despite permanent nature, there is a 2 to 5 in 1,000 chance that if it can fail, okay, causing accidental pregnancy. If it does so, this can occur in the tube as you have experienced in the past. So there is higher chance of ectopic. That is another point which you are like trying to make her aware. Slowly you're trying to move her away from the going for a permanent method, which is ligation. So it increases not only this but the other thing which has traumatized you in the past. So then you come around to saying yes, so in addition to that, when done at younger ages, less than 25 at times, women do report having regrets and have come back to us at a later point in time, wanting pregnancies. And this can be emotionally and psychologically harmful for individuals. Other than condoms, I must inform you that there is no other method, including this, which protects against sexually transmitted infection. And apart from the anesthesia risk, there is also risk of injury to the bowel, bladder, major blood vessels. But this risk is minimal. In your case, it may be slightly more increased because you had a previous surgery. Add, okay, any previous operations, cesareans, anything, including her ectopic which she has undergone, can add to the risk. Hmm? Secondly, I had not said DNC. That was an assumption that you made. I said I had medical termination of pregnancy. Mode, you could have asked me, but don't make assumptions. Okay? So, like those
Okay.
small things become errors in station. Uh, so then in case of complications, additional treatments and procedures may be needed like blood transfusion, repair of damaged organ like bowel, bladder, ureter. So am I clear on this so far? So what you're trying to do is you're making her it sound like you're just providing the information. You're not trying to act paternalistic in any way or trying to sway her decision making at all. Okay. So if the procedure has to be reversed, okay, additionally, it involves another major surgery. Does not guarantee that conception will occur after that naturally. And still, the chance of ectopic pregnancy will remain. So you're basically telling her that you're going to cause damage to the tube, which is already something which was existent before. So the procedure for reversal again is not funded by the NHS. Okay, am I clear on this? All this so far? Then she will say, "Oh my God, like okay, I was not aware of all this thing." Moment that happens, that stage is reached, then you pitch what you need to pitch. That is LARC. There is other methods of contraception which are also known to be more effective than sterilization and need not even be taken on a daily basis or remembered. These are called as LARC. Have you heard of any of this? Could I discuss this? Then briefly put a platter in front of her, which is telling her what are your options. So there are hormone injections which can be given. Who? Yeah, sorry, excuse me. Anybody said anything? Dr. Ramya? Hello?
Yes, ma'am. Yes, ma'am.
I thought someone raised. No, never mind. So hormone injections, which can be given every 3 months, hormone implants, which can be put under the skin, or intrauterine devices, which can be put in the womb, like coils, which can be either containing hormones like Mirena or non-hormonal containing a metal called as copper, which is copper. These can be used for up till 5 and 10 years respectively. So what you did is you put in front of her and these options and briefly described them. Then you need to tell that these are more effective in preventing accidental pregnancies. Also, advantages can be reversed or removed anytime if you wish. So, would you want me to discuss any of these? Then, usually role player will go to ask you one or two because they cannot say that tell me pros and cons of all of them. You'll never end up finishing the station. So usually they will pick one and try to ask you about it. So as I said, tell me more about coil. So you can tell that it is, I'm not in favor of hormones, that means probably. So a small plastic device which sits in the womb releases copper and which is toxic to the sperm and doesn't allow the pregnancy also to attach in the womb. It is 99% effective, can be kept up till 10 years and you can remove at any point of time. On the other hand, it may need a small procedure for insertion. It has a 1 in 20 chance of falling out or expulsion and a small chance of going through the womb during the insertion and the coil threads not being felt, infection in the womb, painful or heavier periods at least in initially, and in case it fails, it can unfortunately again cause a pregnancy in the tube. Hmm? So, which can be a serious complication. So, for these reasons, we always advise to check the threads from time to time and come immediately if you have any pain, discharge, lost threads, or prolonged abnormal bleeding, or periods are missed more than 7 days. Hmm? So, at this point of time,
Okay.
you ask like this is a plan which has been now. Still, there is potential for history taking if you're going ahead with a copper coil and previously you've not asked You can ask the pertaining questions here. You understand? Like when you're explaining all these things, so you can say if you've forgotten, say LMP, or when was the last UPSI and all these things, whether she's used reliable contraception till now, discharge, okay, abnormal bleedings, these are contraindications, right? So you'll be asking those and you'd be making a proceeding with the management plan if at all. Okay,
Okay.
right? So in addition, what else? Patient
Yes.
safety. She's 23, young, no? Higher risk for STI.
Sexually
No,
transmitted.
yes. So say
Yeah,
even if she's
condoms
not
essential.
symptomatic, yeah, not symptomatic, swabs will be taken now, offer you antibiotic for insertion, and advise to continue usage of condom to prevent sexually shared infections. Give counselors if you've not given first. That is why I said give it first only, so that you don't forget it later. Hmm? All patient safety points
Okay.
covered, only then you get a 2 in this. Okay?
Okay.
Hmm? Okay.
Yes, ma'am.
Yeah, right. Little exhaustive, but okay.
Excuse me, Dr. Ankita, can I ask one question, please?
Okay.
Do you think that
It's me,
the
just not Dr. Ankita.
Uma, ma'am. Ma'am, she is
Uh,
Uma. Uma,
yeah,
ma'am.
it's
oh,
okay.
sorry, I'm sorry, I'm repeatedly doing
Okay,
this.
okay. It's okay, it's
Sorry,
okay.
sorry for
Yeah,
that.
fine, fine. No,
Yeah,
no problem.
there is
Yeah.
written Uma also, or sorry.
No,
Yeah.
no, it's okay.
So that
Tell it.
other procedure, do you think that we shouldn't explain more, because otherwise we cannot finish? So that means only we'll mention that and little bit only 1-2 line we can say. Then we can ask her that she has any preference. Then when
Yeah,
she will tell that no, I like coil or I like injection. Then I can explain that one in a details. Yeah.
true. Yeah, that's usually how these stations, where there are multiple options available to you, usually that's how they proceed. For instance, there is two ways in which a tubal block has come, right? Bilateral tubal block. So you take them through till the history, and then you're supposed to tell them these are the options right now. If you do confirm that there is a block, we can do a surgery for removal of the block. We can do a bypass all of that and do IVF directly, or we can go for surrogacy or adoption. What would you like to discuss? So then the role player takes you through like where exactly it is supposed to be headed. So they will guide you. Don't keep asking them. That is very important. Like, what do you want me to talk about? What do you want me to talk about? Where do you want it to go? In difficult stations initially, like difficult task where somebody is very, you know, adamant, insisting on this, like in this station, adamant on taking getting a sterilization, explore around that area, dig around it, try to find points which will help you to, convince otherwise, and highlight those first. Then role player comes around, then they start guiding you. This is how it's supposed to go.
Right.
Okay,
Do you think
so
that
this,
vasectomy need to explain that she discussed with
yes.
her partner about vasectomy or not?
Yeah, other options as when you're proceeding and you're pitching, you can ask.
Yeah.
But in this task, one of the histories that was missed was about the partners, right? Which is she's living with a boyfriend right now, but she's not been in long-term relationships as such. So that's how it didn't come up because
Hmm.
she was not in a that way. Hmm?
Right. And you
So
explained that tubal blockage, that one, that
hmm.
this is hysterosalpingography, that there was a tubal blockage.
Yeah,
So,
yeah,
you know that that one, there is a hystero salpingosonography. That one also there is a one option, and keyhole surgery. So we
correct.
can explain the other method. After that IVF, if it is failed, that we can see that there is a two both sided, there is a blockage, then we can mention about the IVF. But before that, we can explain the keyhole, that laparoscopic dye test and
Yeah,
histero
I'm
salping.
telling you, I'm telling you after all that has been done. See, first you will say what it means, what this report is and what it is saying, but it can be spasm, right? You done that. Then you have to say we have to confirm and we have the following options for confirming. Beyond
Right.
which point the role player still asks you, what happens if I have the blocks actually? What will you
Yes.
do?
Yes.
Then that is the time you have to talk about all the management perspective. Now, one variation is that she takes you towards speaking of cannulation, and you have to use the points in cannulation. And
Yeah.
that is a hysteroscopic cannulation, she asks you. The other station is about when she starts asking you about surrogacy of all things. Like she
Yeah.
says, no, that I have severe needle phobia. I don't want any tests. I don't want any surgeries. Just directly tell me about this. This what happens. So that
Mm-hmm.
these are the two ways in which it can come up.
And another thing also, she's complaining why there is a pain, so much pain during the hysterosalpingography
Yeah,
also.
yeah, right.
So
In the beginning.
some they mentioned that that to repeat this hysterosalpingography with adequate analgesia.
Yes.
This is
So
also
that
could
is
be.
pre what the stage which we are talking about at this point of time. You can that those are your options for confirmation, right?
Yeah.
So you will briefly have to tell her that we can give with painkillers. She'll say no. You don't have to stop with each option, right? You tell her all the things how you can confirm, or we do this, or we do this, and then she'll say, so what happens if I actually do have blocks? Then tell me. So that's how they guide you usually.
Yeah.
Very
But
important is keeping on. Hmm.
my query
Yes,
is another
you
thing,
have to
that
tell her.
why need to repeat it? Because usually here they give this with analgesia they do this that hysterosalpingography. So why?
Precisely. In the recordings that even we do, there is one question which is always asked is, did you receive any pain relief before the procedure? And the role player
Mhm.
says yes. So then this option is out again. Repeating it
Right.
is out. Okay.
Yeah.
So just that is how you have to confirm with her.
Then I don't need to repeat that one, isn't it?
No, 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 you
Yeah.
don't have to.
Yeah. Thank you very much.
It's the same thing under same conditions, you will get similar results, right?
Yeah.
So it's like that.
Thank
All right. Okay. We were going to the next station. It's the participant who did it is here. Dr. Sadia, you're there, right?
Yes, yes.
Yeah. Okay. All right. So much difference between your station and this particular station, right? Now let's take a look at yours. Thank you with me so far. 1 second. Anyone has any other queries in that? No, right? Yeah. Okay. So in the second one, as I have already told you, what is the difference in the way the question is phrased in this situation? It's very different. Again, you will have some forms in front of you. Please be on the lookout for these forms, which will be kept on the table. And sometimes they are not handed to you by the examiner. They'll just be lying on one side. These are like props. You have to see if there is anything kept. You have to pick it up and start using. All right, which means you are expected to fill the form. Very essential part, which again is more important in this station, is because she's been married and she's in a stable, kind of relationship. What is the one method that you didn't speak about, Dr. Sadia? Option. Hello.
Sorry, I didn't get you.
Vasectomy.
Vasectomy. Okay. So we missed vasectomy in this particular station. Okay. Let me take you through the key now. Is firstly, this one begins very typically, and you have your obstetric, medical, surgical, all these problems. Then you have to explore. So what else have you tried for contraception in the past? Okay, How have your deliveries been? All those standard questions that you asked me. You basically establish that she's a low risk for surgery kind of an individual who's had completed a family probably and doesn't want to have anymore. While you are asking each method, make sure that you've spoken about all alternatives, right? Including vasectomy, including vasectomy. In this particular station, you have to speak about, are you aware about long-acting methods also, which contain some hormone injections or hormone implants or coils being put in the womb? She'll then tell you that, yes, I have had a coil put that has fallen off, okay, several times, and it doesn't suit me. And hormones also cause me to have all this bloating, as she said. And I get bloated and I get pain, headaches, all this thing. I don't want to use that. Then I've also completed family and I need to, go for a permanent. I have discussed that with the consultant. Pitch vasectomy always, because it has a higher success rate, which is 1 in 2000 accidental pregnancy rates, right? Which is quite significantly higher. Hmm? So speak of that. She'll say maybe partner doesn't agree or doesn't want it for whatever personal reasons it is. All right. You have to realize that in sterilization, okay, rather than me wanting you to elaborate much on, you did speak a lot about how the procedure will be done, what exactly will happen during the process, and what will be happening in the post-operative period, peri-operative period, how you'll give sort of enhanced recovery program and what she's supposed to be watching out for. But more important things do exist in this particular station, which is talking about one, failure rate, okay, and if in future, when I asked you, see later, is there any other risks I need to be aware about sterilization? That is when you brought up the chance of failure and maybe ectopic will happen. Okay, so that should have come slightly earlier because the consent has to be exactly how it is given here. This is what the marking key will have for you. Okay, so as you're filling, we have already described that first you will write the patient's name, okay, full name maybe, first name and family name, date of birth, okay, tick whatever it is, write the NHS number, all right, and write your health professional, that is consultant's name here, okay, and a job title, whatever it is, registration number, and say that as you said. So I will explain about the pros and cons of the procedure and what will exactly be done in the procedure. And in the end, if you are happy to go ahead with it, you can put your signature here. And meanwhile, I put my signature here. So you put your sign and you put your name first only. Write that. Because when you walk out of the station, that is what will be checked first. If you've left any of these blank, you're not going to pass the station. Okay, mark down for not having filled the form completely or correctly. I am just saying that essentials need to be written. Now, only so much space will be given to you in the exam also, and the form exactly look like this. All right. So you will have to fill in very briefly what about the intended benefit or about the risks of the procedure. Very, very briefly, you will have to write down. But these are the essential areas in the form that you cannot miss. Hmm? Am I clear so far, Sadia?
Yes.
Okay. So first start off with that, and then move on to taking her through the risk. So then say that I will put the intended benefit, which is a permanent nature of contraception. Enough, permanent nature contraception. Hmm? Or prevent pregnancy permanently. Is it 3 words? You write down and will be done under general anesthesia. So let me take over here about general anesthesia and then you move on to other procedures. No, you move on to the risk factors now. Okay, after having spoken. So you have to say that during this time, what we will do. You're not going to write down the procedure by itself. So you are going to write down, just explain to her that this is what we do. We do a keyhole and we take put clips on both the tubes so that we block the portals for the sperm and ovum to move across and prevent a pregnancy. Then after that, you speak about there are serious complications and there are common complications you have to be aware of, which would include any laparoscopy related, like any pain, bleeding, infection can occur, and there can be sometimes injury to the bowel, bladder, okay, uterus, blood vessels, etc. And we may require additional procedures in order to repair anything. Sometimes we may need to open up, okay, do a open cut surgery also. At times, if too much bleeding occurs, then we may have to give blood transfusion. These are additional things. Like you can write blood transfusion and you can write laparotomy for repair. Enough. Hmm? So then you move on to the more important things in sterilization, which is she has to understand that this is of a permanent nature and a reversal of it will involve another major surgery, as the same points that we mentioned in the last one. Another major surgery will be involved in reversal. It is permanent. However, it has a failure rate of about 2 to 5 per thousand at in 10 years, which is it is uncommon. If you do get pregnant, then you can have an ectopic pregnancy, which is pregnancy within the outside of the womb, not within anything, outside of the womb, and lead to serious complications. Also, women have reported having regret and want reversal of the surgery, leading to another repeat surgery. That will not get funded by the NHS. Even if you do the reversal, these are points that now you have written down. Now, next points which I'm telling, you may not write. Okay, like if you do a reversal, it may or may not allow you to conceive in the future. If conception occurs, then because of damaged tubes, again, ectopic chances are very high. And there can be a psychological trauma or because of the regret. Okay, people can have depression, etc., etc. Sometimes we are not able to complete the procedure by the chosen method, which is also a serious and frequent risk. And reversibility of this hysteroscopy doesn't come up actually in this station. It's not doesn't come up. Okay. So as with any surgery, as you have mentioned all the other risks of the surgery, you do that. Then you go on to talking about post-operative and all that, if time permits, because these are the main things on which you will be marked. And then additionally, you can add to this, like you will get admitted on the day you're supposed to come nil per oral probably on that particular day, or can have light fluids. And we will follow enhanced recovery, that we will mobilize you very early, give you adequate painkillers so that you can move about, and very next day we can allow you to go home. If you have any red flags, which is blah 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 blah, you can come back. And like missing periods, okay, or any fevers or any pain or any which you cannot find bearable, or any excessive bleeding, anything occurs, you can always come back. In the future also, you need to look out for any missed periods and do an ultrasound very early. Okay. In addition to that, condoms are a good way of preventing any sort of sexually transmitted infection. So usually we do that is the only method, and sterilization will not prevent. So here you are not saying recommend condoms for prevention. You will say that although this, I have to tell you that condoms are the only way of preventing sexually shared infection, and sterilization surgery doesn't ensure that. So that much is enough to mention, make a mention, because she's, you know, may find it offensive if you say it in any other way, like why will I have this STI exposure and all that. So this is how you complete all the information. Do not ask the role player, are you aware about the permanent nature of this? Are you aware of the whether it is not funded by the NHS? Because how is she going to know this? This is what she has come to discuss. Your job is to tell her all these things. Usually she'll say, no, I don't know. What about this? So waste of time. So you can cut down on that. So we will finish in time. Towards end of any consent, always make sure that you mention to her that this signature does not mean that you have to go ahead with it. I have explained this thing to you. You can take a copy of this with you home, and At any point of time, if you change your mind, you can withdraw a consent. Okay, that is an additional consent related point, very, very specific to any and all consent stations that will come. Okay. All right, let us take a look at the answer key, which has gone quite well as expected.
Hello.
Yeah, who is this?
I'm Sadia. I want to ask
Yeah.
question when the stable relationship patient we told about the safe sex practice, they tell that we are in a stable relationship, why we use the protective measures. So how will I tackle this question?
No, you're not. That's what I said. You don't recommend the condoms. You're telling her, I am informing you that condoms are the only method which prevent against sexually shared infection. If she doesn't want to use, then that's up to her, no? Yeah, you say
Okay.
that just informing you that it is the only method which prevents it. When not that, whether it is entirely at your discretion whether you wish to utilize that or not. Or you're not trying to insinuate that she has multiple partners or partner is cheating on her and all that. You're just saying that as an additional information, the condoms are the only method which prevent, and sterilization by itself will not. See, you don't want the patient to make any sort of assumptions. Like they'll say, okay, now I'm safe from everything, and then later on blame you that information about STI prevention was not given to her. So you don't have to have the onus of that. You giving information doesn't mean you insinuate anything on the patient. You're not trying to say. It is all about how you talk. If you say that for prevention of STI, I recommend that you use condoms, then that question will come. She will ask you, oh, why are you saying I have this? So then, okay, fine. Even if that stage reaches, you can still tackle it nicely. You can say that, oh, yes, I understand that since your risk of STI is low, it is your choice whether to go ahead with use or not. That's it. And don't let it become a complication in the station. Okay?
Yes.
Yeah? All right.
And in this consent form, you told me about the reversal. I will talk about this thing in the consent form too, to write that reversal is not funded in the consent form. I wrote this thing
No,
or
no,
not?
you're not going to write that. That's what I said. There are points that you will write, like you will write about failure rates, you will write about what happens with failure, ectopic pregnancy, and all that, and regret. Okay, needing reversal. These are points you will write. What happens after reversal, you need not, but you will mention, you will utter that. Like in case you have the reversal, doesn't guarantee that you have fertility because this is not a consent about reversal, no. So you don't have to write that, but you have to provide information about it.
Okay.
Hmm? Hmm? Yeah,
Okay. Yeah, fine.
so that's it. So agenda, yes, setting was done. Body language I couldn't make out. Eye contact also. And chunked information, yes. To check understanding intermittently. Involved consultant wherever necessary. Sign posted before sensitive info was good. Okay.
Sorry, we cannot see the slide.
Okay. There may be some net issue. Let me unshare and share again. Okay.
Now it is
You
okay.
see? Huh? Okay. Yeah. Okay. So this is what we were looking at earlier. And so we've covered everything. Okay. Now. Okay.
Previous one, please. The previous slide, please.
Next person. Leo. Next person.
Ma'am?
Volunteers.
Yes, ma'am.
Shall I,
Yes,
ma'am?
ma'am.
Okay.
Yes, ma'am.
So somebody.
Okay. There is so many people. Dr. Rajni, I think I put in the chat also.
Yes, ma'am.
Okay.
Later, ma'am. Thank you, ma'am.
Unfortunately, this is my last one. So today. So maybe another time also possible.
Ma'am, I'm doing on the phone, so would that be okay?
As long as you are going to write down what I need you to write down
Okay.
while you are filling the thing. Okay? Hmm.
Mm, can I start then? Ma'am, where's the form?
Yeah.
So, should I start, ma'am?
Yeah. Sure. You're feeling ready, then we start. Of course.
Okay. Okay. Hi, I'm Rajni, the ST5, and you are?
Hi, I'm Uma. I'm the ST1.
So, how are you doing, Uma?
I'm doing good.
So, how
Found everyone very welcoming, and it's been a really nice experience working here.
nice to know that. So, I would like to tell you that we are all here as a family, and anytime you need any help, please don't hesitate to ask us.
Yeah, sure. Thank you.
So, Uma, what I can see that you have a MDT form with you, and uh, you would like to learn filling the MDT form. Am I right?
Well, yes. I believe that I have come across two cases which would require onward referral, and was hoping that I can fill the form and present it to the consultant, so they will sign it. You know, I've never really done one, so I wanted your help in that.
Okay, surely Uma will definitely help you, and I do appreciate your enthusiasm in learning. So Uma,
Thank you.
before I we go further, like,
Mhm.
can I ask? Do you know like what is a MDT form?
Well, yes. So we are doing a referral to a specialist, I think.
Yes, very good. You are a very fast learner. So it is. So MDT form is a form which we send it to the MDT team to decide the further course of action.
Uh-huh.
That team is a like a collection of doctors. It is including the radiation oncologist, the radiation therapist, and the consultant gynecologist, the specialist nurse, and the GP. Am I clear
Mm-hmm.
so far? So
Yes.
they decide on the mode of further action of the patient, so that there is a uniformity in seeing all the patients.
Uh-huh.
So
Okay.
that information would go to the GP, and irrespective of from whichever trust the patient comes from, so there is a uniformity of action, and so that there is a uniform care for all the patients.
I see. Okay.
Can you repeat for me, like, what is a MDT care
So it
means?
involves a specialist group of doctors and their input so that we have a standardized care across all patients. when they referred.
Very good, very good. So you're a very fast learner. Going to the form which I have here. So
Hmm.
first of all, this form is showing the details of the patient. First of all, we should write that. Beginning to begin with, like this, we should write everything in a, like, there should be no shortcut used, and we should write everything in a like a legitimate manner, so that there is no people can understand what we are writing. Am I right?
Mm-hmm.
Am I clear
Okay.
so far? So
Yes, 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 yes.
okay. To begin with, we will write about the patient on the date on which the patient has been referred. So here is the date of the referral, what we can write. And we can also write that, if this patient is we can write the details of the patient. So here we can write the name, the hospital number, the date of the patient, and the GP who is treating the patient, right?
Uh-huh. Okay. Yes. Hmm.
So any questions for me, Uma?
No, no. It's been going quite good so far.
Okay. And so, we can also write here that, has this patient been discussed previously? Like, is this the first time that we are sending this patient to the MDT, or it has been it is a repeated time? Because sometimes there's a recurrence of cancer, and so we need to send the patient again to the MDT team to take decisions. So we also need to write here that, this is it being sent for the first time, or it is a repeated thing?
I see. Okay.
Okay. And we should also write that, who is the referring doctor, and we should have a question for the MDT team to answer, right?
Yes, I understand.
Am I clear so far, Uma?
Yes, yes, very clear, absolutely.
So any questions for me?
In this situation, what do I feel now?
So here she is the here the column is the referring clinician and the referring hospital. So we can write about the clinician who is referring and the name of the hospital, and the it is written here the reason for MDT review.
Hmm.
Can you see here?
Yes, yes.
Yeah. So can you tell me about the patient whom we are referring?
Hmm. Okay. So I had come across two cases and was hoping to fill the forms for them. So there is this 60-year-old lady who had been referred with abdominal bloating, fullness, and distension, and she was detected on ultrasound to have a complex ovarian cyst and ascites. So there was solid and cystic areas as well. Yeah. So that would be one of the cases that I was interested in.
Okay. Has she? Is it the first time that we are referring that patient to the MDT team?
Yes, yes, she's a new patient.
Okay. So since she's a new patient, then we can write here that, it is the first time that we are sending her, and since she has never been operated before, so we can write here like she is a pre-op patient,
Hmm.
right? Okay. And for the and what do you think is the probable diagnosis what we have made for this patient in our mind?
Well, I was more thinking of more in terms of cancer of the ovary.
Right, very right. So we can whatever the diagnosis what we have made, we can write here that the provisional diagnosis that we are thinking of ovarian cancer,
Huh. Okay.
right?
Yes.
And whatever the investigations we have for this patient, we should also write here. So we have
Okay.
the if we have the imaging of her, we can write here. And um, and uh, so s- since we want a management for her, we can tick
Hmm.
on this box,
Okay.
right? And also we should tell that if the patient is aware of the diagnosis.
Uh-huh.
Okay.
All
Any
right.
questions for
Uh,
me, Uma?
She's not yet aware of the diagnosis, so I will fill it in this manner. Anything else I need to write down?
Yes, and when we have what we should also write about how she presented to us, like what were her complaints and what is her
Hmm,
like her history and examination findings, and we should
I got it.
also write about the RMI status. So, do you know about the RMI status of the patient? Like, are you aware what is
No,
this term about?
no, not really. I know there is a formula for it, that's all. What do I need to
Yeah,
put down?
yeah. So the RMI status is calculated basically on her like a menopausal status and the ultrasound findings and
Hmm.
her CA 125 score.
Uh-huh. That I remember was around 670.
Okay, so we can so here is the column where we have written the RMI status, so we can write the status write the RMI score here, and also we should write about the performance status of the patient. So um, are you aware like what is the performance status of the patient?
She's doing quite well. She's moving about, so I believe.
Okay. So in that case, our performance status would be like one because she's completely ambulatory
Hmm.
as what you are saying. So and based on and the rate, we can also write about the whatever investigations have been done, serial investigations, and if a tissue biopsy has been done for her, that also needs to be enclosed. Am
Okay.
I clear so far?
Yes, absolutely.
Okay. So how did this session go today, Uma?
Yeah, it was very informative. Um, I think yes, I will be able to fill these forms on my own now.
Okay. I'll give you a couple of reading material regarding this MDT reference, and any other help you need, please don't hesitate to ask us.
Yeah, sure.
Okay. Thank you for your time.
That's good. Thank you. Hmm. Okay, tell me.
Uh,
Hmm.
Ma'am, I like while performing, I like since this was a form and it was in the phone, like I had forgotten what domains had to be checked, like I had to do in the perform
Hmm.
in the
Okay.
status. So that ways my station got little haywired. So I was just like I didn't know because I was on the other page.
Mm-hmm, mm-hmm. So I had kind of requested to log in with web actually in the beginning, but it's okay. We'll still, take through. So at what point did you realize that you're missing out on one of the most important domains?
Like right in the beginning only, I did realize. And but
Okay.
but I had already started. So after that, I started asking about the patient.
Mm. Mm. So it was not in the beginning. It was if I was looking at the time because 5 minutes had almost gone at that point of time. So it was like at halftime when the info gathering started, and which was the biggest problem here. And it's not you. In fact, a lot of the times when anybody is going in and performing a station, often they can forget what is being tested and what exactly is the agenda, which is why the formula of the exam is to keep looking at what is expected out of you. Okay, what is expected is written here. Keep glancing at this, and that also helps. Really. Okay, let me show you the station. Okay, explain the importance of oncology MDT letter. This will carry marks. Obtain relevant information. This is what I'm giving marks, and show how to fill the MDT review form. I, as the ST1, told you I had two patients to discuss. So you can see how lengthy the station can be.
Yes.
So, but at the same time, I'll tell you that it's not that lengthy also. There was if it had gone as per expectation, then you would have realized that the second patient, I mentioned that it's just a stress factor which is added by the examiner. It is just that she had a lady who was 28 and had dysmenorrhea and dyspareunia and had ovary which was showing ground glass appearance. A125 was normal, and I wanted to refer that as well. You just had to tell me, not take her through the filling of the form. You just had to say that this appears to be like a dermoid, sorry, not dermoid, endometriotic cyst, and therefore doesn't require MDT referral. Okay. I believe that a lot of your time was wasted in talking about MDT and its importance. Yes, you have to, but use concise statements, very crisp way in which you can talk about what MDT is and why referrals need to be made and why it is important that you fill a good form. Okay, right? We are talking about the letter, which is not just MDT, maybe for standardization of treatment across the NHS or maybe whatever it is. But finally, why are you filling this form? Why is this form such a vital piece of paper? Because when you are referring, firstly, you talk about MDT, which is a specialist doctors from our oncology colleagues and Macmillan's nurse and other surgeons and our gynecologist, etc., will be oncologists. All these will be uh, taking a part in this meeting and discussing what is the best mode of treatment in each case individually. So it is very essential. Okay, that is the importance of it, right? It is very essential that your form has to be complete in all information and all data which they need to evaluate in order to come up with the best strategy. That is why this form is so important. This is what I wanted to hear about MDT affiliate. Okay. Hmm?
Okay, ma'am.
So once you do that, then you go around asking, okay, I believe you have some cases to discuss, right? Because there is information gathering. Hmm?
Yes,
So can
ma'am.
you tell me more about these cases? So ask everything. Don't leave it halfway. You cannot, like I told you, till the ultrasound report, right? So your job is to ask me, okay, were any tumor markers done? What was the result of the tumor? What was CA125? What was the other patient? What was her ultrasound finding? CA125. And does the patient know about the diagnosis or not? Okay, how are they? Are they well supported? What is the um, what is the performance status? Is the patient moving about well or are they bedridden? So these are the kind of questions in information gathering that you would ask. Okay, firstly that will come. Hmm? Then goes you go through your saying, okay, let's take this form and see how we fill it now. So in this very essential that along with that you write down whatever is being filled as you are explaining. Like here we mention the patient's full name, okay, and NHS number. We never use any short forms. We write the patient's full data details about the address, okay, and the GP's name also, our consultant's name also here in full, and it has to be legible handwriting. I think you mistakenly used the word legitimate instead of saying
Okay,
legible.
okay.
Yeah.
Yeah,
Sorry,
yeah, yeah.
slide cannot see. Slide, please. Cannot see.
It's visible, dear. To me,
No,
at
cannot
least. I
see information. Next one. The previous one.
Which one?
This one,
This.
yeah. Yeah, yeah.
Okay. This is just a brief outline how I've written how you should go about. There's not much. Of course, I'll be telling you more about that. So,
Thank you.
then the correct assessment of the patient, like presenting illness, bowel bladder issues that they have, menstrual obstetric, depending on what the scenario is, right? So you have to say, was this patient is postmenopausal, right? Confirm. Hmm? Then the age could be something perimenopausal. Then again, you'll have to confirm that because it is important for you to calculate RMI, right? That's what you're trying to. How you are deriving towards this is through information gathering. You will be doing your advice. You understand what I'm saying? Without this, often, very often, it is important to find out whether the patient is sexually active or not for the MDT also, because certain treatment procedures will affect their sexual life. Okay, and this needs to be discussed in a meet, like in vulval cancers, for instance, right? So all this will be important. You understand, Dr. Rajni?
Yes, ma'am. So, like, how do I'll ask you. Tell me more about the patients. What you have. Then
Hmm.
she'll tell
Hmm.
me something that, like, she told me that she has a patient who has a
Correct.
like.
Hmm.
So
Hmm.
then what will I ask her? Can you tell me about her parity and her immunopausal state, like the similar history template what we follow? All the things I'm going to ask.
All what is relevant you will ask.
So basically
Okay.
the same template I follow and pick from there only whatever is relevant, right?
Pick what is relevant and ask that. Like
Okay,
menstrual
okay,
sexual, then mobilizing or not. That those are specific things in MDT referral. Like what is the
okay.
performance scale of, then patient aware of diagnosis or not, or aware of the suspicion of diagnosis. That also is important. Hmm? There were a lot of things that you repeated here. If you're wondering why the time ran out, it is because you explained a certain thing and then later you came to the form again. There was similar explanation which was happening. And about your awareness of diagnosis, that was, I think, spoken of 3 times in the station. So if you avoid that repetition, it is very much possible to do this. Okay. So that way. Hmm? So you get the history out of the way first, very quickly and briefly, like asking about all these things. Family history of is any family members affected with cancer, all these things, and awareness of patient with diagnosis, performance scale. Performance scale, in fact, had a star point in my thing. So you would have gone from a 2 to 0 directly. This was not us, but fortunately, you have done this in the form of either the form, because you read in the form. So that's one way of doing it. So then communication with colleague was okay. You were not threatening, friendly, uh, everything. You were appraising also, chunking information, checking my understanding. All these things were being done. So no issues there. And yeah, coming to safety and applied clinical knowledge in this, there wouldn't be too many boxes here, but a lot of things for you to talk about, including by looking at the form itself, about what all you need to fill in. While you are filling it in, you would show her and advise her this is what you need to write down. And RMI, you have to write down. I'm not saying you have to do a calculation here in this situation, risk of malignancy index. Now, you may not be given all these columns. Please beware. This is one form of it, which is like having all the data in the tabulated form. But I can give you another example which can be shown whether it's just one blank this way, and then clinical details and blank. Okay, so they didn't mention RMI and all these things separately to test your knowledge of what you understand about this. So you will say that we need to write down presenting symptoms of it and past significant medical history, which is in this case nil. In addition, we will need to write down, or I must write down, the ultrasound findings and risk of malignancy index. Which, do you know how that is calculated? Then you go on to explain. So it is based on the UMCA 125, right? So ultrasound, menopausal status, and CA 125 level. So we multiply. You need not do mathematics. It is not a math exam. So you can just write down ultrasound, okay, but you need to know the score markers. So I said there is ascites, and I said what else is there? Multiloculated and solid cystic area, correct? So it is 3, correct? So you have to
Yes.
justify and say, no, it is 3 because the following are positive, 1, 2, 3. Then other, what are the other factors in that? Bilaterality and
Menopausal state. Yeah, that is it.
ultrasound.
Ascites, multiloculation,
Hmm.
bilaterality.
Hmm.
Uh,
Solid areas.
huh.
Hmm.
And one more is there.
Metastasis.
Yeah,
Metastasis, right?
Metastasis.
meds, correct. Meds. So, menopausal status, again 103, she'll get a 3 over there. And you write this thing. You don't have to do a calculation. You don't have to do this by 9 and write it and waste time. Just you can show 3 into 3 into say 125, and you have to display that you know what are in it. Enough. Write down the performance status. Very essential question in MDT form is what clinical question are you looking for the MDT to comment on. Okay, so what does that mean? It's a mandatory thing, by the way. So that is you have to write saying we want initial best possible mode of treatment to be discussed. Okay, whether it will be surgical or it should be chemotherapy followed by surgery, what it is. So this is what the MDT will have to discuss and answer. What is the best mode of management in this situation? This question can vary as per the situation. Like if it's a recurrence or something, you'll write down what is the further course of action or whether radiotherapy is to be given or not. Like, so you understand, get the gist of it, right? Based on that, you will write down. And so you're basically in applied clinical and patient safety, your knowledge about these types of cysts and what needs to be referred to MDT and what are the components of the MDT form, that is what is being tested. Okay. Additionally, one very essential thing for you to mention is, of course, signposting for further learning. You would have probably done it if time was there. And towards the end, you have to say that you will not sign this form. You understand? Other forms we've been saying, I will put my signature here and there and all of this. But in this particular form, you have to say, we can fill this up and you have to take it to our consultant. If they are happy with the information given, then they will make the signature and we can send the patient for onward referral. Yes?
Yes, ma'am.
Good. Okay. There's one question about this particular point about CT or CT scan before doing an MDT referral. That is entirely up to the consultant discretion. This patient qualifies for an MDT referral directly as well, but you could choose, and most likely you would choose to do scans, further scans like CT, MRI, which will help the MDT discussion, and this will be discussed with your consultant. Okay, Dr. Neha.
So, ma'am, like while explaining, do I also have to tell that MDT, like what would be the communication with colleagues in this be? Like, do I have to tell what members are included in the MDT team, or I don't? I have to skip that.
No, you have to mention that.
Okay.
Involve other colleagues and consultant wherever necessary. That is one box. But this is, see, primarily this is communication with colleague only, no? This is a colleague task. So in communication with colleague, you'll have a lot of points in this, apart from this. Usually, other areas, there will be communication with colleague, which will be only, onward referral or involving this one, that one. A structured discussion when you have communication with colleague, it is usually about how you talk to the examiner, one, okay, respectfulness and all that, politeness and stuff. And second thing is about involving other specialties. So because these are just 2 points, what ends up happening is if you don't say one of them, you end up getting a 0 or a 1 instead of a easy 2, end up losing marks. So wherever there are lesser boxes, it's easier to lose marks. Remember that. Wherever there are more boxes, you tend to say some things or the other, right? A long list will be there. Out of 10 points, you may say 7 or 8 points. You're still okay. Depends on what the type of decision. Okay, so I think any questions in this? Yeah. Hello. Okay, so about face-to-face, these are the kind of some tasks that you can get. Do not get very worried, or everyone is in the same boat, okay, together. So you don't have to, you're not singled out or anything. And this was the traditional way of the exam, so there is absolutely no necessity to worry about it. Okay, it will just be how it's used to be or supposed to be, which used to be easy. Don't get worried because somebody tells you this is something different and you're not prepared for it. No, nothing like that is going to happen. Okay, practice just on the tasks and how to handle mannequins a couple of times, and you should be through. Okay, so I think that's it
Excuse me,
from my
Dr.
end
Mohan.
today. Yeah,
In this
tell me.
case, do you think that materials should be, we can ask about the ovariances, this to read it or no need?
Sorry, I didn't
Materials
understand.
about to give the materials.
Yeah, signposting for further learning. No? That is always there. I said always, always, always there.
No, no. So what we can say about the materials to give the ovariances to the
Huh.
guideline?
Yeah, I can give you some reading. See, don't need to dig your grave by specifying what you're giving. Reading material about ovarians is premenopausal, postmenopausal. I can give you for further learning, and you can fill this form and get back to me. So I can take a look at it, okay, and take it to the consultant accordingly.
Okay.
That is it. Okay. All right. Okay. Good night. Thank you, everyone, for attending.
Thank you very much.
Thank you, ma'am.
Thank you. Bye.